So we've had a very active and vivacious discussion. It's going to continue. The second panel of this morning enlarges the boundaries of our discussion to the entire world. In fact, I think for our first speaker, we can say it enlarges it to the entire universe. Beginning this phase is Professor Uwe Reinhardt, the James Madison Professor of Political Economy at Princeton. We all know that Professor Reinhardt's one of the leading health policy experts in the world. He served on a number of government commissions and advisory boards. I'll just mention a couple that seemed pertinent. The Congressional Physician Payment Review Commission, the Kaiser Commission on Medicaid and the Uninsured, and the World Bank External Advisory Panel for Health, Nutrition, and Population. Notably, in the context of today's discussion and on its focus beginning, at least in New Jersey, in October 2006, Professor Reinhardt was appointed by Governor John Corzine to chair the Health Reform Commission for the state. Professor Reinhardt, I think all of you are going to understand very soon why he's one of our most popular professors, students and faculty alike.
Well, thank you, Dan, for this nice introduction, and Dan and Richard Keevy for organizing this conference. Healthcare seems to be slipping from the political agenda in the presidential campaign, but obviously we should keep the conversation going, and this is part of it. I also want to ask the panelists, distinguished panelists coming from close and far, to join us and share their insight, and the audience. I'm impressed so many of you made it here, and obviously it shows people do care about this issue. Commissioner Howard is here. We worked together. She constantly mentions the Reinhardt report, and I shudder. The deal is this. It's the Reinhardt report when we do good things, and it's the Gould, the Michelle Gould was the executive director, the Gould report when we screw up, and that's how we had agreed to do this. I know Senator Vitale, he spends his working hours trying to figure out how to make life better for people in New Jersey. Those of us who know him, he really deeply cares. But Commissioner Howard and he and others have to work within this structure that exists. And there I have, you saw already a little bit of my temper earlier. If you want to see another taste, there's a letter I wrote to Governor Corzine as part of the report, and we put it in the folder. When you were in the car, when the governor said, "Are you serious to put this in the report?" And I told him, well, I actually wrote this when I was in a euphoric mood. you should see what I write when I'm in a bad mood. So he's actually very lucky. Finally, I should point out, yesterday I heard a presentation on the health care system of Taiwan. They implemented health reform in 1995 and moved to universal coverage. And Zhongmei Cheng, who is sitting here, gave that at the U.S. Chamber of Commerce yesterday. There was an international conference. And I thought it might be nice to share her slides with you. They're out there on the table. Now, the title was Universal Healthcare Worldwide, and how do other nations do it? First of all, I mean, you look at these slides, we didn't have numbers. You've got to have the body count here. That's part of any discussion. This is from a very authoritative paper, John Holohan, Alison Cook, and they trace how the number of uninsured grew. But if you look, the insurance status of Americans is given here for adults, the red bar, and the yellow for children. Most are in the employer-based system. Now, here's another interesting thing. You take any randomly selected group of health policy analysts who spent their life doing this, and almost to a man and woman, we would say, if we had to do it again, no one in his wildest dreams, drunk, would ever build a health system based on an employer-based system such that when you lose your job, you lose your health insurance. I mean, you'd have to be vaguely meshuggah to do this. And yet that's what we did. This is what makes America so fascinating. Here we have the lack of insurance by income group. I think I have the numbers. Yeah, in 2006, for one person, federal poverty level was $9,000. For four persons, $20,000. And you can see that it is a problem of poverty, the uninsuredness, and you have a lot of children that are uninsured. And of course, the wealthier, the higher the income, the fewer people are uninsured. There's a very nice report, the National Institute for Healthcare Management, NICM. I think if you go nicm.org, and I have the website here, Understanding the Uninsured, and they break this down, and this is an interesting table here. They have this category, they worked with the population survey data, that of the 47 million uninsured, in theory, 12 million, in fact, are theoretically entitled to be on public programs. But we heard Senator Vitale, 14-page forms. I think in Florida they have a 30-minute fade-out if you're on the web trying to fill this in after 30 minutes. Remember how the web expires? And you say, well, this just, we must try harder. And the answer is no, this is deliberate. There was a paper written by my colleague Richard Zeckhauser about 15 years ago, Kennedy School, where he even said quite explicitly the way to manage entitlement programs is to hassle people who try to get access to them. It's there, a policy recommendation by a PhD in economics. We call this transaction cost, and this makes sense to economists. But that is what you then get. 6 million children who are entitled to public insurance and can't get it because the barriers to getting at it are so... Now, that isn't stupid. That is clever in order to control the budgets. In fact, the budgets for these things aren't there. And then you see, again, this is such a nice picture that shows you the insurance status, private and public, by income class. This is really a neat, clean picture that you ought to burn into your brain. And you can see the being uninsured is definitely a matter of income. It isn't that you so often hear, and there are think tanks who sort of project that message, that you have these irresponsible yuppies who'd rather go to Martinique than buy insurance because they know they get free health care when they get sick. I don't think that really fairly describes what goes on. Now, the interesting thing that nowhere in the industrialized world, the OECD, would a health system generate data like that. If you went to healthcare conferences in their place, the only time you would ever see such data is when they describe the American system and then say, whatever we do, we must never have the American system. That foreign system in foreign conferences, the kiss of death is to say, if you do this, you will have the American system. That'll absolutely, whether it's China or Taiwan or Germany, or we were in Slovenia, that'll kill a proposal there. So it's amazing how the rest of the world actually refuses to adopt the best health system in the world. Somehow they managed to get near universal coverage, and that raises the question, how do they do this, or how did they do it, when it has eluded us for over a century now? And I guess, Richard, that was the mandate you gave me. Now, how do other nations do this? Every system in the world has to perform, every health system, the following function. Financing. It has to be sucked out of household budgets. Government never pays for anything, nor do employers. It comes from the budgets of people. Either taxes or premiums. There's really no other way to do it. Well, I mean, in the US, you have to add to one. You can temporarily have the Chinese pay for this stuff and the sheiks of Araby, but eventually that'll run out. We have been using that, though. Somebody then has to pool risks to somehow aggregate healthy and sick and pool the risks so that somehow the fund is predictably manageable. And that is the issue of insurance. It can be public, or private. And the purpose of that insurance is to protect individual families from going broke over health care. We often pretend that it's only about getting access to care, but that is not it. If you go to Europe or to Taiwan or Japan, the thought of a family where a member is stricken by cancer going broke would be an utter obscenity. And there was a frontline television program aired on PBS where they asked the conservative president of Switzerland from a conservative party, does anyone in Switzerland ever go bankrupt or broke over a health care bill? And he looked shocked, and he said, of course not. He said, that would be a scandal. And that is how they look at health care. Now, I'm not saying we should copy that, but that is why they have what we don't have, because they consider that obscene. Somebody has to produce and deliver health care. Somebody has to purchase it. And there's a big debate. Should that be the patient or should it be a third-party payer? And if third-party, should it be government or should it be private entities? Someone has to worry about the workforce and technology. And then stewardship, somebody has to regulate. Every soccer game, every hockey game has to have a referee with rules, and so do markets. The idea that there could be markets without government interference is drummed out of a freshman's head in the first lecture. To say, you know, you can check that idea. You cannot have a market without rules. Well, you can. In Hoboken, they sometimes ran it with switchblades, but even they have rules there. Now, health policy actually, what is it? When you teach it, it decides who should perform each of these functions. Who is best suited to that? Patients. There are people who say consumer-driven healthcare, patients should control costs and quality. Should it be private commercial entities, private non-profit entities, government, quasi-governmental entities with regulatory powers, which what Germany uses, and so on. So you have to decide who does this, and then the organizational structure within which all of that takes form, and who should regulate and what these regs should be. Now, it's not an arbitrary matter to decide who should do this. What you start with is that what is the social goal of the system? What are the goals it should actually achieve? And when we teach it, we say, well, you should get access to care, you should have financial protection, people should be satisfied with the care, and you can specify these goals. But among them is the distributive ethic of healthcare. And, you know, we have a distributive ethic of pizza. If you don't have the money, you don't get it. And we accept that as a people. And the question is, do we accept that in healthcare? And the answer is the Europeans have settled that years ago, and the answer is the Americans have not. In Taiwan, the Supreme Court had said, as a matter of right, no Taiwan citizen can be denied health care for want of ability to pay. We in America have not been able ever to agree on that as a proposition. But the Germans have that, everyone else does. Once you have decided the goals and the ethic, you can then talk about who should do which function, which is an empirical matter. Who purchases health care more efficiently? Medicare, the traditional, or Medicare Advantage, the private health plans? You could then, that's a purely empirical question that does not involve ideology at all. It should be noted here the word efficiency that is so often mentioned in healthcare has a meaning only when you specify the goal that is supposed to be efficiently reached. I teach my students, if you want to go to San Diego, the efficient route to Seattle is actually quite irrelevant. A less efficient route, a sloppy route to San Diego is better than an efficient route to Seattle if you want to go to San Diego. Now, if there are economists in the crowd, I usually say that twice because they can't get it, but most people would understand it. The typical economist would go to Seattle and say, hey, it was efficient. I didn't want to go here, but geez, it was efficient. But most other people don't think that way, which distinguishes economists from humans. Now, the typical sequence for making health policy properly, and the way it is done in Canada and in Taiwan and in Hong Kong and everywhere else, is you first of all discuss the goals. What are we supposed to do with this system? And then you say, how do we structure the system, who does what function, etc. We don't follow that in the U.S. We never discuss social goals or social ethics. Ideally, we really should to get this done right. Now, what are the ethics you could pick? One of them is to say healthcare is a pure social good that should be available to all on equal terms. That's a very clear ethic. You can write this down, and Canadians, for example, do. It's a one-tiered health system. Or you could say it's a pure social good for all but a small elite. You always have to have the elite buy out so they don't get discontent and so on. So have a special deal for them. Let them not be part of the social contract, but 90% are in the social contract. Or you could say healthcare is just another private consumption good like food and housing and shoes and clothes, and it should be distributed the way we do those goods. You hear that very often in the United States. For many Americans believe that's how it should be. Now, I would put, crudely speaking, Canada here, although Canada's elite, when they have money, do come to the U.S., so in a way, the upper tier for Canada is the United States. The lower tier as well, because many poor Americans go to Canada to get cheaper births and free health care because they're fairly lenient in that regard. Europe usually has a small 10% that are in a private system with their own deal. And then this is the U.S., but not consistently so. I'll end you up. We Americans don't really have a clue of what we want to do. Every conceivable health system in the world, we have it within the U.S. I'll come to that later. The distinguishing characteristic of U.S. health policy is we make it incrementally and without any overall roadmap, ethical roadmap, that gives us a coherent set of goals. What is it we actually want to achieve? And what is the distributive ethic that is acceptable? For example, is it acceptable that families should go broke over health care? They have to sell their house. We have no agreement on that in the U.S. And that, I think, I could stop now, is the reason why we have, for 100 years, not achieved the goal other nations have long ago achieved. And that is the reason, I predict, why we will not reach it for another 50 years at least. And thereafter, in fact, the Chinese may own us, and God knows what they will do. So if you go to Canada, they actually, the commission, Romanov Commission, had a whole chapter on ethics. You go to Germany, they always mention principle of solidarity, the French too. They literally say, oh, we can't do this because it violates solidarity. And we generally never do this in the U.S. So then what are these alternative structures? So here comes the egghead. You've got to have a PhD to do what I'm now doing, but you will understand it. You make a grid like this with lots of letters, and then ask who owns the providers and operates them. It could be government, it could be private nonprofit, it could be private for-profit. I don't think I left anything out. This is why you can do this when you're drunk. And then who organizes the financing? You can have social insurance. The distinguishing characteristic is that contributions to the insurance pool are based on ability to pay and not health status. It's not per capita, it's a function of your income. Clearest case, Germany, France, where that is so. And then you could have a single-payer system, Canada, Taiwan, for example, or you could have a multiple carriers, Germany, or Medicaid managed care, or Medicare Advantage. They're actually social insurance, called Medicare, government financed, but with multiple carriers doing the purchasing. Or you can have private insurance where the distinguishing characteristic is that premiums are set actuarially on the basis of health status, and economists believe if you have private insurance, that's what you really got to have. And if you don't like it, then don't have private insurance. But this is the only way to run this business properly. And then you can have non-profit, for-profit, although there's virtually no distinction between a non-profit and a for-profit Blue Cross, as far as I can tell. And then no health insurance, which is out of pocket. So if you look at socialized medicine, that's box A. That is what the Soviet Union and their satellites had. This is Hong Kong Hospital Authority, very fine system, by the way. They have that. Cuba still has it. Who else has it? Where's another pure? Sweden at the county level, yeah, you could say it's county-based, but it's increasingly private. No, but there's a pure system, it's crystalline pure, as nowhere else in the world, pure socialized medicine. First of all, let me ask you, is it good or bad? Let me have a show of hands. Socialized medicine bad? Oh, most Americans in Congress everywhere say, socialist medicine, you get socialist medicine, the end of the world, you're in pure hell. And I always say, what do you got against my son? And people say, what do you mean? He's a Marine or an ex-Marine. He's a veteran. That's what you have for him. Purely socialized medicine. Government owns everything. Happens to be, who else? No, Medicare is not socialized medicine. It's not. I'll show you why it isn't. Socialized medicine, the government owns all production. That's what it means. So Americans who run down socialized medicine whenever they can, reserve it for the veterans. I leave you to figure out what we think of veterans. I don't know. I'm just an immigrant. I'm trying to figure this out. These systems, they are an extreme form of social insurance because the government, it's really socialist production. And the government, that's why we call it socialized medicine. Prior to the independence, the Russians have it, and of course, the US. The next system is social insurance only systems, and they have the following features. Under government auspices, large risk pools are created. Like in Germany, it's private non-profit carriers, but it's government controlled. Individual is ability to pay. Production is private, mixed. So I'm talking here single-payer system. Canada, Taiwan, Medicare is a single-payer social insurance system that buys health care from government clinics, it buys it from private non-profit hospitals, it buys it from private for-profit. Or you could have this system, which is Medicaid managed care, or the German system. But the point is, the insurance side is social insurance, based on ability to pay. And examples of this, the Dutch model, the German Bismarck, the Swiss model, Medicare, and so on. And where you can have social insurance, you have private health plans that bid competitively for the privilege of purchasing on behalf of the social insurance, Medicaid Advantage or Medicare or Medicaid managed care, and then they do deals. From then it's private managed care. This is Medicaid managed care. So that's social insurance. You can have that. The proposition I have is, and we tell to Taiwan or China when they do health reform, as long as the financing side is social insurance, you can have the most entrepreneurial delivery side. It doesn't matter. They play all to the same songbook, so it doesn't really matter. The Canadians don't seem to get that, but they should learn. You could have a for-profit hospital in Canada, wouldn't make a damn bit of difference. Like we have for-profit hospitals selling to Medicare. Then you have, so that's what I mean by that. Then you have private insurance, which is basically our employment-based system or individually purchased. And then we have these systems. Basically, you have choice, the advantages among insurance. If you care to have choice among insurance, I must say I personally have never stayed awake at night worrying I don't have free choice among insurers. I do care about free choice about doctors and hospitals and therapy. Insurers, I don't really much care about. And many employers give their employees only one carrier. That's your choice. So where is that different from the Canadian health system, where you got one choice, your provincial plan. Premiums are actuarially set. Health status is medically underwritten, is taken into account. And they do involve enormous administrative costs. There's no question about that, because it's very complicated to run. Just to show you, there was a study done by the McKinsey Global Institute, and they wouldn't be what Morton Downey Jr. would have called pablum-puking left-wing liberal think tank. These are some vaguely to the right of center. This is a young crowd, but those of us old enough to remember Morton Downey Jr., that was one word to describe liberals. They compared Germany and the U.S., making everything equal, actuarially equal, and found Germans spent $1,000 less in 1990 than Americans did. Americans actually got $390 less health care, fewer doctor visits, fewer hospital days, fewer pills than Germans. Germans consume more real health resources. We pay much higher prices. We spent $737 more paying higher prices for the same thing. But what caught my eye, we spent $360 more just for administration. And the Germans complain and kvetch about their bureaucrats. Imagine. Well, here we don't like bureaucrats when they wear hush puppies. That is, when they're public. When they're private and wear Ferragamos, somehow we don't seem to mind. But they're still bureaucrats. They sit in an office and fill in forms. That's what they do. And then there's this other. So there is that as a system. Now, to conclude, so these are all the choices. That's how. So there is not one single approach. Every country uses different approaches to attain the same goal, though. And the different approaches are rooted in culture and history, and basically they're what political economists call path dependent. On where you were before is where you go next. Now, very few people and nations anymore have pure systems left. Private sector enclaves exist in every sector, particularly the English have been far more open to that now. Our system has everything in it, because when you think we have the VA, we have Medicare, we have Medicare Advantage, we got the huge private insurance sector, and we got tons of uninsured. So we got everything. So therefore, when you say describe the American health system, the correct answer is everything. We do everything. And we don't really have to study the Swiss system or the Canadian system. We could just look at Medicare here. Now, therefore, my conclusion is, given our strong preference for the status quo, which is enforced by the interests defending the existing system, my colleague Stuart Altman at Brandeis has a law. He says, in health reform, everyone's second best solution is the status quo. Everyone has their preferred plan, and then the second best is the status quo. Our health reform will never have a pure system, no single-payer system such as Medicare for all, no purely market-driven system. We'll have what we now have, the mosaic, and tinker at the fringes. And the Massachusetts plan, which I'm glad you have a whole session on it, and you will describe this, Nancy and Brian, is a classic expression of that. So was Hillary Clinton's plan, so is the Obama plan, really. The more revolutionary plan is the McCain plan, but that's not on our radar screen at the moment. So anyway, that's it. Thank you very much.
Thanks, Professor Ronhard. You didn't disappoint. I've heard great things about you, and now I know why. That was terrific. So coming to us from the Century Foundation is Maggie Mayer, the author of Money-Driven Medicine, The Real Reason Healthcare Costs So Much, and Bull, The History of the Boom, 1982 to 1999. A former English professor at Yale, Dr. Mayer has written for Institutional Investor, The New York Times, and Barron's, where she served first as senior writer and then as senior editor from the late 80s through the late 90s. Recently, she's written about Medicare reform and its potential impact on more general reform in our healthcare system. Dr. Mann, please.
We're going to begin today with an advertisement, and I'll be quiet so you can hear it.
Enjoy the things you love. You may not know that most knee replacements. With any surgery, there are potential risks and complications. You'll be amazed at what a difference a knee replacement can make. Visit genderknee.com or call 1-877-GEN-KNEE to find out more about the only knee created for women. The Zimmer Gender Knee, the knee women are talking about.
Now, Zimmer advertises this knee. They call it the bespoke knee, a custom-made knee for women. They say that it fits a woman's unique anatomy. The question is this true? Is the bespoke knee for women really better for women? The answer is no one knows. There, I got it. Okay. We do know that it costs twice as much as a plain vanilla knee, okay? Twice as expensive. We don't know if it's better. After putting it on the market and after persuading Medicare to pay for it, Zimmer has said that they're going to look into the question of effectiveness. They say we have studies ongoing to clearly identify what the clinical benefits are. Now, Wall Street, nevertheless, is quite happy. Problem? Okay. Wall Street is quite happy with the situation because, as Michael Madsen, an analyst on the street, says, no matter what the science concludes, pursuing female knee surgery patients makes sense from a marketing perspective. It's a hook, a marketing hook or strategy that these companies can use to appeal to those patients and give them something that maybe their competitors don't have. And sure enough, after Zimmer came out with its knee for women, another company came out with its knee for women. In fact, these knees are a little narrower, but there's no evidence that they're better. What we do know is that in the past, when both men and women were using plain vanilla knees, different sizes, of course, depending on how tall, short, etc. they were, women did just as well with the plain vanilla knees as men did. There were no complaints coming from women saying, you know, my husband, it works well for him, but not for me. So there doesn't seem to have been a need for women. The marketers invented a need, and then they filled it. In the U.S., we don't try to compare drugs and devices to the existing drug or device that they're trying to replace. The reason we don't is because manufacturers strenuously object to the idea of head-to-head comparisons. If we had head-to-head comparisons of a new drug with the existing, always cheaper drug, there would be winners and losers. And when there are billions of dollars at stake, who wants to be a loser? No one. So we don't do these comparisons. Instead, the FDA requires only that the manufacturer test its new entry against a placebo, showing, in fact, that it's better than nothing. Meanwhile, the manufacturer controls the trials and decides what information it will release from those trials. Think of it this way. Imagine a society that let its automakers oversee crash tests on new models, letting the industry decide what to report, when to report the results, as it sees fit to the government and to consumers. No National Traffic Safety Administration funded by taxpayers overseeing the trials. No Insurance Institute for Highway Safety funded by insurers overseeing the trials. Instead, the auto industry itself in this society finances and controls the trials. If a test turns out badly, it may not report it. It may wait a year, do the test a few more times, see if it can get the results it wants, and then report those results. And if this all sounds fantastic, this is, in fact, the way we regulate the safety and quality of new drugs, devices, and procedures in our healthcare system. Moreover, if you take a close look at new products, you'll often find that there is very little difference between the new product and the old product. But the new product will almost always cost more. Now, device makers themselves recognize this, that there's often very little variation in the new product. In fact, in 2005, Ray Elliott, who is the chief of Zimmer Holdings, alarmed investors at a Bank of America conference by warning them, there's a lot of bell and whistle stuff in this industry. Over the last 5 or 6 years, you got pretty good money for stuff that was pretty fluffy. But today, if you think you're going to be able to take a device and spray it red and add $1,000 to its price tag and say, this is still the good old days, you're wrong. Basically, Elliott was saying we're not going to be able to continue to get away with this. But what has changed since Elliott said this in 2005? One thing that's changed is that Elliott's no longer CEO of Zimmer. I don't think he was fired. I think that he was preparing to retire, and he thought, you know, why don't I just tell them the truth at this one last conference? Otherwise, not much has changed. Manufacturers continue to resist head-to-head comparisons of their new products. So we never really know whether the new product is better. We just know that it's better than a placebo or better than nothing. Now, the U.S. is the only developed nation in the world that has chosen to turn healthcare into a largely unregulated, for-profit enterprise. Other nations tend to actually monitor and even regulate safety and quality. When it comes to artificial knees and hips, many countries have joint registries. And what this means is after the new knee or hip is implanted in the patient, it's registered in a database, and then the doctor continues to inform the registry how the patient is doing, whether the knee or hip is working out well, whether the patient's experiencing pain, is it wearing out, is a second operation necessary. All of this data is collected around that knee or hip in the database. Regulators then use that data to force manufacturers of artificial joints to justify why poorly performing hips or knees should remain on the market. In some cases, regulators use the data to insist that the product be withdrawn from the market because it just isn't serving patients well. Companies also can use positive data to market their products, and the volume of data helps good technology stand out. So it's useful for doctors and patients in many ways. Another way to ensure quality is to compare the product to existing products before agreeing to cover it. And this is what the UK does. Its National Institute for Health and Clinical Excellence, called NICE, reviews the research about a new product. Then it consults with patient groups, organizations representing doctors, manufacturers, and their rivals. The competition often has an interesting perspective on the new product that you're trying to bring to market. Then an independent academic center draws up a report, consultees comment on the report, changes are made, an independent appraisal committee hears testimony from clinical experts, patient groups, and caregivers. They draw up a report that's sent to all consultees and commenters who make further comments. And let me add that you'll notice that manufacturers are consulted and they testify, but they don't vote. They do not have a seat at the table to vote. But they do have an opportunity to tell NICE everything they know about their product and why it should be approved and covered. A final document is drawn up, is submitted to NICE for approval. NICE then issues its decision and sends out guidelines to healthcare providers. NICE is insulated from politics and lobbyists. It doesn't, once NICE makes a decision, no one has to vote on it. It doesn't have to go back to Parliament and say, this is what we decided, is that okay? Once NICE decides, the guidelines are issued, and once NICE approves a product, National Health Service of England and Wales is required to cover it. It would be as if here, once this institute, this Agency for Comparative Research, came out with a decision, then Medicare had to cover that product. NICE also produces guidelines providing guidance on the management of diseases and recommending particular treatments that are most effective for a particular set of patients. And let me add, this is not one-size-fits-all medicine. NICE will recommend a treatment for patients who fit this profile, another treatment for patients who fit that profile. Doctors are not required to follow these guidelines. NIH has to agree to cover it, to pay for it, but doctors can decide, no, I don't want to use that treatment. Every individual patient is unique, is different in some way, and for whatever reason, a doctor may decide, for this patient, no, there's something else I want to do. But doctors and hospitals now follow NICE's recommendations about 89% of the time, which is pretty good, and is certainly a much higher percentage of following guidelines than we find in this country, where doctors and hospitals tend to do what they want to do, what they've always done, whatever, but they're not big on following guidelines. The NICE technology appraisal process has earned credibility because the scientific review is very rigorous and is also very transparent. None of this is behind closed doors. I think that as of last summer, they began to make their meetings public, which is extraordinary. Now, I want to talk about the difference between cost effectiveness and comparative effectiveness. When NICE evaluates a treatment, it weighs how much benefit the treatment gives, how long the benefit will last, and how much the treatment costs. The UK is operating with a much smaller healthcare budget than we have per capita, and so NICE must try to maximize delivery of care within the constraints of its budget. That's why NICE considers cost effectiveness. NICE asks questions like, if this drug is only going to give the patient another 6 months of life or 3 months of life, is it worth the price? By contrast, the Comparative Effectiveness Institute that Congress is talking about would not be looking at cost effectiveness. It would focus only on the clinical effectiveness of treatments and alternative treatments for a particular group of patients. It would select the treatment that is best for a particular group of patients regardless of cost. It might be the most expensive treatment, it might not be, but that wouldn't be the question. The question would be, which is most effective? So the agency would not be rationing care based on price. At this point, we probably don't need to, because there's so much low-hanging fruit in our system in the form of ineffective, unproven treatments, devices, and drugs. And here I would go back to the bespoke knee. There's really no evidence that it's any better, and it's really not clear, no matter how expensive or cheap it is, why we should have it in our system and why anyone should be paying for it. So what we're talking about really is evidence-based medicine, medicine based on medical evidence, not direct-to-consumer ads, value-based medicine based on the benefit to the patient. We're not asking how much should it cost the manufacturer to produce this. We're asking how much benefit will the patient get? And we will only pay for things that give patients the most benefit. I think it's quite possible that before long, Medicare may begin to negotiate for discounts on drugs. And if that happens, this kind of information could be very useful in deciding which drugs are we or are we not willing to pay for, and how much are we willing to pay. If there's only this much evidence that the product is this much better, we probably don't want to pay twice as much for it. Make no mistake, lobbyists will fight this tooth and nail. But as David Mechanic has said in his book, The Truth About Healthcare, at some point, we as a nation will have to decide whether we wish to design our healthcare system primarily to satisfy those who profit from it or to protect the health and welfare of all Americans. I think, or I hope at least, that we're getting ready to make that decision, and it seems quite obvious which direction we should be going in. Thank you. Yeah. Yeah. Okay. Thank you.
Okay, you work on that. Put this on your belt. Let's put this here. Thank you very much, Dr. Mayer. I recently was at a meeting where a large number of pharmaceutical executives were holding forth. It was an informal setting. And I can tell you that at least half of the meeting was devoted to teeth gnashing and hand-wringing over this federal legislation on comparative efficiency. So I think you're onto something, and I think it is viewed as a threat by the pharmaceutical and device industry. So for our final speaker of the morning, we welcome Dr. Ezekiel Emanuel, who chairs the Department of Bioethics at the Clinical Center of the National Institutes of Health. A practicing physician, oncologist, Dr. Emanuel has published widely on the ethics of clinical research, healthcare reform, international research ethics, end-of-care issues, euthanasia, the ethics of managed care, and the physician-patient relationship. As a member of the Institute of Medicine, Dr. Emanuel served, on President Clinton's Healthcare Task Force and the National Bioethics Advisory Commission. Dr. Emanuel, thank you.
Thank you. Actually, despite that introduction, you know I'm an idiot. No one would agree to be on a panel following Uwe Reinhardt, the finest speaker in the whole healthcare field, Maggie, the best blogger on healthcare, and stand between you and lunch. So, dumb, I think, is the answer as to why I'm up here. It's really great to be in Princeton. If I can figure out how to make the slides move. Press something. Hold on. Yeah, it doesn't seem to go. Okay. So, one of the things I like to do is to survey people, and I think it's a very important survey because it tells you something about where we are as a country. Considering all aspects, how well do you think the American healthcare system functions? Oops. Very well? How many people think it's functioning very well? There's one up there. Okay. Moderately well? Fair number of people. Fairly well? That's the mode. Not well at all? Oops. More. Okay, so we're weighted down to the bottom. The only place I've gotten more than one or two people to endorse very well is at the Massachusetts Medical Society. Here's another question. Considering all aspects, how happy are you personally with the healthcare services you receive? Very happy. How many people? More than before. Moderately happy. There's the mode. Always is. Fairly happy. Not happy at all. This disjunction, by the way, is very important, Senator Vitale would tell you, for why we can't get health care reform in this country. Because whatever you think about the system, the fact is you are relatively well satisfied, and that makes any change nervous-making. On the other hand, I do think increasingly we're like this cartoon. Between congratulations and get well, it says good luck with the American healthcare system. And that's really where we're at. This is a section about international comparisons that might inform us. And let me just say, I was at a recent meeting with a lot of CEOs, and the following statement was made, which is 100% true and was completely rejected by almost every CEO there, which is the American healthcare system is number one in one and only one health measure, cost. It is not number one in almost any other measure. There are a few very small, subdivided, stratified samples where you can get us number one. But there is no other health measure. And that should give us a really important wake-up call, as you have heard from other people. Now, I want to criticize, at least implicitly, the theme of the talk of the presentation here, because I don't think we can talk about universal coverage. I don't think we should be focusing on universal coverage exclusively, because I don't think we can get there unless we focus on sustainability. And I don't think you can get sustainability unless you focus on the other two big issues in the room, cost and quality of care. We said some things about cost here, and I want to emphasize it in a second, but we said very little about quality, and I don't think you can get any of this without going to the quality side. So without cost control, there can be no sustainable universal coverage. If you look at the data, and there are lots of data out there, every 1% increase in health insurance premiums causes 164,000 or 300,000 Americans to lose their private health insurance. It dumps them out either uninsured or into the public market. And as you know, into the public market means taxes go up to cover them in some way or another. You can look at these data in lots of different ways. If you look at the increase in healthcare costs, a 10% increase in healthcare costs drives down the number of people who have insurance in this country or coverage of any form by 0.55% of the total population, so 1.5 million people. So if you keep letting costs go up, we are chasing our tail. There is no way we're going to get to universal coverage. That doesn't mean, I should say, that we should do cost control and quality first and universal. You got to do it all as a package. And part of the problem I have in most healthcare thinking is we don't have the package right. I think what Uwe said when he put up his 6 points that a healthcare system has to do, at least implicitly, is you got to do them all together and you got to make the system work together. Having different parts is a problem. Now let me just emphasize another word about cost here. We got to put this all in perspective. In 2006, the last year for which we have reliable data, we spent $2.1 trillion. The extra zeros there, that's not a mistake. That's how many zeros there are in trillion. Now, you are a really smart audience. I know that. This is Princeton. How big is a trillion? Most of you have no idea. So, 1 million seconds. How long ago was 1 million seconds? Some of you are really quick at math and will realize that is last week. How big is 1 billion seconds? Some of you are old enough in this audience to remember that's when Richard Nixon resigned the White House. It's a good marker. How much is 1 trillion seconds? 30,000 BC. 15,000 years before anyone stepped foot on this continent. Okay? It is a number so big we have no idea. And we're spending 2 of them every year on health care. It's this next slide which really should make you worried. Not how much we're spending today, but what I call the tsunami slide. This is healthcare costs into the future, and it's just going to overwhelm you. There is nothing else we're going to be spending money on if we don't get this issue under control. And this is no joke. By 2050, if we don't do anything, the federal budget is just Medicare. Forget it. Education, defense, Social Security, environment, forget it. That's why we really do have to be serious about costs. And there's no way to control costs, I believe, without changing the delivery system. You can try price controls. You can change what you're going to pay doctors. Instead of $70 for a visit, we're going to pay them $30. You can do that till your cows come home. Doctors will figure out how to get around it. It is a broken, failed cost control mechanism, and I'll have more to say about that in a second. We have to get to what Maggie's referring to, and I'm going to talk about a little here, which is unnecessary, marginal, fragmented, poor quality care. We can get some savings out of administrative, and actually I think we should do that. It's $75 billion there for the taking, according to the McKinsey Global Institute, and there's not one iota of health that are sacrificed for it. Requires redesigning, however, the whole insurance market. It's not a trivial reform. There are lots of other things we can do, but we can't change the slope of that curve unless we get a handle on the quality of health care. So I'm an oncologist, as you heard, and let me say a few words about my field. I'm not going to criticize a cardiologist. I could do that very easily. I won't criticize the orthopedic surgeons. That was just done. All right? This is equal opportunity criticism. So among men, this study was published just last December. Among men 66 years and older with low or moderate grade prostate cancer, not receiving radiation therapy or prostatectomy, and last year, to give you a number, there are over 200,000 men fit this bill. A third of them received androgen deprivation therapy. That is, they either got an injection of a medicine that blocked their testosterone, or they got an actual surgical castration. There is not one shred of evidence this does anything for longevity, and it certainly makes their life worse because it creates impotence and a lot of other problems. It's not recommended by even the urologist organization or ASCO, which is the American Society of Clinical Oncologists. And even more disheartening to me, academic practitioners were only slightly better than private practitioners. A third of the men in this country with this condition get this drug for no benefit and some harm. And why? Just try to figure out how much doctors get paid for giving that injection. Here's another one. This is my current favorite. February 2007, the FDA approved the use of Avastin, a drug made by Genentech, for metastatic breast cancer. This was the data published in the New England Journal. Now, you guys, I don't know how familiar you are with reading data. This is progression-free survival. So this is, if I keep doing a CAT scan or something, how long before the breast cancer grows. But this is overall survival. Now, you don't have to be an oncologist to read this slide. You see the two lines overlapping. That just tells you there's no difference here, right? There's no improvement in anyone's overall survival. There was also no improvement in the quality of life of people who got Avastin. And Avastin people actually had higher rates of neuropathy, that's tingling in their fingers, infections, hypertension, and fatigue. How much does it cost? Genentech announced that when it got approval, that it will cap the annual cost to a woman with breast cancer at a mere $55,000 per year for that no improvement in overall survival. By the way, you are all paying for that. Taxes through to Medicare, your premiums at private insurers who are all covering this. And this is but one of a number of other examples I could give. And again, I'm not even talking about the cardiologists, the orthopedic surgeons, and on and on. That leads me to a conclusion, which I've already stated, and I'm going to restate because I think it's the most important point I have to make, which is true healthcare reform must address cost, control, and quality. And therefore, true healthcare reform requires fixing both how we pay for healthcare, which is what the early panel was talking about, but more importantly, how we deliver care. If we don't change how we deliver care, we can't even do the first part, getting everyone into the system. There is just no way it is going to work. So the question is, what should be done? Now, you heard that I work for the U.S. government, and I am required by law to tell you that the views expressed by this person do not represent their views. This is a little civics test. I have to do this even though it's obvious to you that that's the case. Who is this guy? You know that. Who's this guy? Secretary Leavitt. Little civics test. Secretary of Health and Human Services, the largest by cost government agency in the government. Who's this guy? Zerhouni. He's the head of the NIH, my nominal employer. Did you see that slide? All right. If you have to use these slides. So what should be done? Uwe has this great slide, goes from A to O, too many boxes for a simple guy like me. So I'm a reductionist, which is, I think all healthcare reform is a variation on 4 themes. And there are slight variations, and sometimes those variations are very important. When you get to legislation, those variations are very important. But I think for the average voter and public in America, there are really 4 different possible reforms we can have in the system. And I'm going to talk briefly about each one of them. There's incremental reform. There is individual and/or employer mandates. Employer mandates was sort of the flavor du jour in the 90s. That's what the Clinton plan was about. It's gotten to individual mandates because the employers just won't tolerate it. There's single payer, and then there's my plan, guaranteed health care vouchers. I will tell you I'm going to be completely objective in evaluating all these 4 plans. Now, incrementalism is what we do in America. You heard Uwe make a prediction that it's 50 more years of this stuff. This is tinkering around the edges. You know, we add a drug benefit to Medicare. We're going to cover all kids with S-chip in the new administration if it's Democratic. We'll get electronic medical records for everyone. And McCain's proposal fits right in with this. I heard it was referred to as more radical, but it's radical in a kind of peculiar sense. You know, it gives tax credits instead of the tax exemption for employer-based insurance so that whether you get your insurance through the employer, you still get this benefit. It has reform of the individual and small group health insurance markets to allow interstate competition, and there are a few other things in it. But it's a tinkering around the edges. Now, what's characteristic of this reform? And again, I want you now, as you're thinking about these reforms, to remember you're voting at the start of this talk. The main appeal of incremental reform is not that it's a good reform. No one gets up and says, this is the best reform for the American healthcare system. They say it's politically feasible. Now, that means it's a triumph of politics, what we have rather than what we ought to have. If you like the current system, then you should love incremental reform. So someone who voted that the current system's working very well, this is your plan. If you don't like the current system, and I think the majority of you voted that way, you should reject these kind of incremental reforms because they will not change the fundamental dynamics of the system, and they will not get us to where I think at least you want to go. So let's look at mandates. And here I can't do a comprehensive summary, and there is no doubt I will do violence to the proposals in trying to summarize them. I think you can understand mandates based on three principles. First, they require individuals and or employers, depending on how they're structured, to buy insurance, even if only catastrophic coverage through a high-deductible plan. They set up these insurance exchanges to pool previously uninsured, self-insured small businesses, maybe others, into one pool to get you lower rates. Now, almost everyone who looks at this says that's a very important mechanism to make the insurance markets much more efficient. It wingles out a lot of administrative costs there. And finally, if you're going to require people to get health insurance, and health insurance is pretty expensive in this country, the average family plan is now at over $12,000 a year, you have to provide subsidies. And typically, like Massachusetts' proposal, the subsidies are up to 300% of poverty, which is about $60,000 for a family of four. Now, I can't analyze this in detail, and you're going to have a whole panel on it that probably knows more about this than I do. But if you expand this to the whole country, the sum total of the amount of added money you need to throw into the healthcare system is about $100 to $150 billion. You don't have to trust me on that. That's what Hillary Clinton said her plan would cost. That's what the Center for American Progress said their mandate kind of plan will cost. That's what these plans cost. Because you get no efficiency really out of the system, a little on the insurance market. You don't change the delivery system, and you're simply adding more money to cover the uninsured. This is a fill-in-the-cracks plan. It relies on the current system and tries to make as few changes to get as close to universal coverage as possible. By the way, those aren't my words. Those are the words of Jonathan Gruber, who is the MIT economist who helped design this plan and is one of the leading advocates of the plan. That's how he sells it, because he has his eye on political feasibility and says you've got to make as few changes to get as close to universal coverage as possible. And as you've heard, and you'll hear again, the real Achilles heel is costs. Costs are just going out of this world. Let's look at single-payer plan. Again, I think you can summarize it in three simple ways. Single national health plan, so that you put everyone into a pool for all medically necessary coverage. You reduce administrative costs because you get the intermediate insurance companies out of the way, and you reduce administrative costs down to 3 or 4% of Medicare. Now, there's a good question as to whether Medicare, despite the 3 or 4%, is actually doing everything it wants to. Just remember, when you see those 3 or 4% numbers, collecting data on quality of care, that's administrative costs. Not all administrative costs are bad. Some of them actually can bring value to the system, and part of the problem here may be we don't distinguish between good administrative costs and bad administrative costs. And main cost control under single-payer plans has typically been use a reimbursement system where you can adjust the prices you pay to doctors or hospitals. The interesting thing about most single-payer plans in the United States is they are a radical reform of the financing system with very little reform of the delivery system. And that, I think, again, leads you to the same problem, the same quality problems, the same cost problems in the long run. So I don't think, in general, they're as appealing as they are to many people, because I don't see a big improvement in quality under those plans. And it relies on price control, which is a pretty failed cost control mechanism. And then if you look at Medicare, there's a whole lot of politicization of decision-making. It's not just that Medicare covered Zimmer because Medicare was decided to be generous this week. It really liked women. It didn't want to be accused of discrimination. there's a lot of political pressure on those organizations to cover these things and do these things. So here's my alternative. And again, I said I'd be completely objective. So we've proposed a voucher-based plan, which gives every American a certificate or voucher to obtain a standard benefits package through an insurance company or health plan. The package is modeled on what congressmen and senators get, and the health plans are paid a risk-adjusted premium, which is a very important mechanism to prevent selection. Because if they're paid risk-adjusted, more to cover for the sick people, they will not avoid people who have cancer, diabetes, or heart disease and just want to get the healthy 25-year-olds. Americans would have free choice of any qualified plan in their area. They would also have freedom to purchase more services than the standard package with their own money, tax money, so that it would create some disincentive to buy a lot. These vouchers would be funded by a value-added tax dedicated to health care and not going to other things and not general revenues. In exchange for that, most of us who get our insurance through our employer would get a wage increase. State taxes would go down. Most of you may or may not know that about a third of state budgets now go to health care, and this plan wipes that out. Private sector organizes and delivers care. Eliminate the tax exemption for employer-based coverage. Very unfair, unjust tax incentive, now worth $210 billion. It's the single largest tax break in the American tax code. Double the mortgage deduction. Phase out Medicare, Medicaid, put everyone into one pool so you don't have these very different fragmented systems. Have a national health board that's politically insulated because it's devised like the Federal Reserve System to make tough decisions like what's in the standard benefits package. Have an Institute for Technology and Outcomes Assessment that Maggie suggested that assesses new interventions, but also collects data on quality and assesses how people are doing in these different health plans. And finally, I think you have to have a medical malpractice solution that not only addresses the malpractice problem, but also addresses the fact that we have a lot of patient safety interventions which don't get implemented because no one is responsible and no one has the money to do that. So how do these compare on the big three issues? Universal coverage. If you look at mandates, there's no way they can get to 100% for a whole assorted reasons. Inevitably, as they have had to do in Massachusetts, a number of people are exempt because health care is unaffordable for them. About the best you're going to get is 97%. Single payer definitely gets you 100%, and our plan gets you 100%. There's no financial barrier between people getting the coverage. They don't have to pay anything. There's no requirement. Cost control, there's nothing built into mandates. I think single payer has a flawed policy, and I could talk to you about various things. The dedicated VAT is a very good cost control mechanism. Quality of care, very little built into either mandates or single payer. And we have tried to build it right into our plan because, again, part of what we believe is you can't get improvements in the system unless you've got the systematic outcomes assessment and link that and allow insurers to link that to what they're covering. I'm going to conclude with talking about Israel. Now, when most people mention Israel, they think of incessant conflicts, terrorism, lots of problems, maybe a robust democracy, maybe archaeology, but they don't ever think of health care. And it's, I think, actually a big mistake. Before 1995, Israel had what could only be described as a terrible system. It had one dominant health plan linked to a union that was running chronic cost deficits. It had about 60% of the population, and dissatisfaction was terrible. Had poor and fragmented quality of care, lots of hospital overcapacity, and great deal of public satisfaction. Sound like a system you know? And, it's a population also that any of you have ever been there is incredibly demanding. Makes us look very much like pussycats. Between 1948 and 1988, they had 12 blue ribbon commissions suggesting changes in the healthcare system. Again, sound like a country we know? How many commissions have we had that have told us we've got to change our system radically? Then they had a crisis in 94, 95. For one thing, there was an increasing privatization of the economy going from a sort of old socialist model to a more market-driven model. A lot more consumerism among young people. They'd been out in the world and they knew that the healthcare system didn't have to be this bad. And there were just pressures on the government to stop this incessant subsidization. They created overnight what no one thought possible. They went through this 40 years of the same thing we are, nose reform, minimal incremental change. And then overnight, things just coalesce for reasons When you go there and talk to people, they can't tell you why. It just happened. Everyone got fed up. They have 4 competing health plans or sick funds. Actually, they're going to have a 5th soon. They offer a standard benefits package defined by the government through the Ministry of Health, but the real control arm here is the Ministry of Treasury. They say how much money they're going to give, and you've got to design a package within that envelope. Once something's on the package, it tends to stay unless it's been supplanted by a new technology. Everyone has to be enrolled in one of the health plans. People can buy supplementary insurance above the health plans, and actually 70% of the population does, typically for things like complementary medicine, coverage to reduce the co-payment with medicines, the ability to go to a doctor if you have a life-threatening illness like cancer, any doctor you want in the country, any hospital you want. Income-based earmark tax to fund the system. So this is what Uwe was talking about before. Funding this on the ability to pay. They have it through their income tax, but you could have it equally through a VAT. They adjust premiums, what they pay the insurance companies or the sick funds, only by age. Now, it's possible to adjust by a lot more things, for illness, etc. The Dutch do it. The Dutch have such a complicated formula. No one knows what goes into the back box, which makes it hard to game the system. Israel has chosen the opposite, just very simple adjustment. Government-controlled, what I like to call quick and dirty technology assessment done each year. It's actually run by all of 4 people, and they agree with NICE about 90 to 95% of the time. And once they've made a decision, it goes through a public comment process where all the health plans can comment, all the patient advocacy groups and disease groups can comment, and the drug companies can comment. But it's really these 4 people running this technology assessment using available data. There's a public professional committee to assess the additions of new services to the standard benefits package. So this is where the doctors and the public and the patient advocates can talk about it. Certain things are carved out of the system: mother and child mental health care and nursing health care. So what do they have? Universal coverage. 100% of the population is covered. No gaps. You can't be left out. Cost control. Healthcare costs have remained at 8 to 8.5% of GDP since the creation of the system because they control the standard benefits package. And again, this is an extremely demanding population. If you look at the cost comparisons between the United States and Israel, we spend in purchasing power parity equivalents $6,049, I think in 2005 this was. Israel spends $2,069, and you would be hard-pressed to find the difference between our healthcare system and theirs, except I can guarantee you they don't cover Avastin for metastatic breast cancer. They have earmarked taxes, so you've got an envelope as to how much you're going to pay. They have technology assessment, and they have reduced the number of hospital beds, so you limit the demand-driven side of healthcare costs. Oops. They have voluntary reporting by the 4 health plans to an academic center. The data is released to the public, anonymized. It's not linked to providers, and it's not linked to specific health plans. And they can also very strictly limit off-label use of drugs because the health plans are legally within their right to refuse to pay for it. And this gives them a pretty good club over doctors going awry and deciding, today I'll try this. Satisfaction is extremely high. 88% of the population is very satisfied with the health plan service they get. My survey here did not suggest anywhere near 88% satisfaction with the kind of system you get. Choice. Israelis have choice of 4 health plans, whether to buy supplementary insurance, and they have choice of doctors within their health plan. Interestingly, 4 times a year, patients can switch among health plans. Only 1% of the population moves each year, and this turns out to be an incredibly strong incentive for high-quality service, because that 1% is complete profit to every one of these plans, because they don't have to add another doctor to absorb that 1%. They don't have to add another hospital bed. And there's very little adverse selection. There are problems. There's a huge, not currently, there's an impending doctor shortage. They don't have a doctor shortage because a lot of Russian doctors came to Israel, but they are facing some of the workforce issues we're facing. Specific areas like radiation therapy, not enough doctors. And so they're confronting much of the issues we are. Despite our exorbitant salaries to doctors compared to the rest of the world, the issues turn out in the United States to be very similar to all the rest of the countries. They do have a hospital problem. Hospitals in this system are very weak bargainers, and they are on the financial ropes all the time. Everyone recognizes that, and they're going to try to solve that problem. And they have some quality of care issues. It's interesting that all funds have electronic medical records. All funds voluntarily report outcomes of their data to this academic center, and they have a collaboration on developing outcomes and quality measures. They do, on the other hand, because each fund has done something differently, have difficulty unifying the data and getting provider-level data to know which providers ought to be out of the system. They have risk adjustment, as I mentioned, on very little. They're actually thinking of solving a problem which we have not hardly talked about in this room, but is a serious problem, the fact that the rich do so much better in health care than the poor, even when they have the same insurance. And so in Israel, they're actually thinking of paying these sick funds more to take care of poor people so that they will actually focus on their health care problems. So I don't know if that's the best health care system in the world. It's certainly much better than ours. It's something we ought to look at. It's something we ought to add to our palette than continuing debate just between the United States and Canada, the United States and Britain. There are other countries in the world that have solved our problems. And interestingly, with many of the same values we have, a lot of individualism, a lot of personal choice. So let me conclude by suggesting I think the exclusive focus on universal coverage is a big mistake, because you cannot get universal coverage unless you do cost control and quality of care also. You simply cannot get it stably over time. I've suggested there are 4 alternative proposals. You should be interested in incrementalism, again, only if you like the current system. If you don't think the current system is functioning, you should not be satisfied with that. I've given you some pluses and minuses about these other alternatives, and we're going to hear more, at least, about the mandate plan in a second. And then I think, interestingly, Israel offers an alternative model that, similar to what we've proposed, and I think the fact that it's functioning well, has that very good cost control, has high patient satisfaction, has the ability to collect quality data, ought to suggest to us that it's something we ought to look at. Thank you very much.
Thanks very much, Dr. Emanuel. So we have about 15 minutes or so, 20 minutes for some comment and questions as we did before, and then we'll be breaking to lunch, and we could have our panel. So do we have comments or questions in the audience? Someone there? Right.
It seems to me, Dr. Emanuel, that what you're suggesting with the last one, that Israel, that is very similar to what Switzerland has and what Germany has and what lots of other international models emulate. But most of those models also control profit within the insurance groups or sickness funds. Does Israel control profit, and how do they do that? And I think that's a big issue that in the first morning sessions we didn't talk about the fact that we don't talk about a package of care, we talk about insurance. And we need to talk about the fact that we have denial insurance, that people lose their insurance for lots of reasons that don't relate to doing bad things. And so how do you prevent that from happening as well?
Okay. Let me make 3 quick points, if I might. The first is I would stop worrying about profit. You want to focus on outcome. You want to focus, are they providing a good health outcome to patients? I don't personally care whether they're for-profit or not-for-profit. I think, as Uwe said, they look pretty much the same. Second, a lot of people, and you heard, and I think the State Health Commissioner will say, focus on the how much is being paid out by the insurance companies in claims. And we want to keep it at a certain level. Let me tell you, one of the most interesting ways to elevate that number artificially, right, be very administratively inefficient. It is not a good number to look at. All right? It is an artificial number, and you will begin to create Enrons in all these companies. They will just start cooking the books because there are various ways to add things on there. An inefficient system looks very efficient on that score because they're paying out a lot of money. It doesn't mean they're covering outcomes. Focus on what you care about, which is healthcare outcomes, and let them decide how they're going to do it. If you give them, let me just finish. If you give people a standard benefits package to cover, and then you give them a set amount of money, and you monitor their outcomes, you are going to get a much better system. Because, you know what? You don't know the best way to deliver care. I don't know the best way to deliver care. He doesn't know the best way to deliver care. We're going to have to experiment with it. And we're going to have to experiment a lot. What you want to do is keep your eye on the ball, not on some intermediate, how much profit are they making?
I think you missed my question. The question was not about nonprofit and how you know, whether it's for-profit hospitals or nonprofit hospitals. That's not what I'm talking about. I'm talking about the fact that insurance companies will increasingly say to you, I won't pay for that. You know, so if you don't monitor how much profit the insurance groups or companies can make, which is my understanding of what they do in Europe, that what they do is just enlarge the list of things that are now excluded. So you know,
Okay.
that would be
All right. So,
one thing but not the other.
I think that there are two good ways of addressing that. First of all, a standard benefits package helps to address that problem pretty well. And the second method is, you know, under our current system, who chooses which insurer do you go to? Do you? No. Mostly, for more than half of Americans, it's chosen by someone else, their employer, right? If you are in control and they do that to you, what do you think is going to happen? You are going to leave, right? What we don't have now in our current system, as the insurance market is structured, is a situation where you as an individual with any effective power can walk when the service is bad, right? Your employer decides that, and your employer's interest may not be your interest. They may not be to cover things, right? So one of the virtues of something like Israel is if you get bad service, you have this voucher 4 times a year, you can walk. And insurance companies, as I mentioned, are very sensitive because every time you walk, their profit goes to 0. We have to restructure the insurance market so that you are an effective purchaser. Right now, you are a terrible purchaser, not because you're a terrible purchaser. We've created a non-market.
Dr. Mary, you have a comment?
Can you add to that? Sort of, the issue of profit, I couldn't agree more with Zeke on this. Profits are actually a small piece of it. The typical commercial insurance company in good years has a margin of 5 to 6%. That is, of the premium, 5 to 6 pennies per dollar are profits. But it's worse now. United's stock is down 46%. The margins are more like 2 and 3. For Medicaid managed care, the margins are about 3%, penny per dollar. So if you took it away, you wouldn't save much. Even drug companies in the heydays, this was before the year 2000, their margin was 18 cents of every dollar sales. But if you calculated that, what percent that was of national health spending was 1.2%. So I had this debate with Michael Moore once. I said, forget about this. The real issue is the wasteful stuff we buy that you really don't need, and the mindless administrative hassle. I mean, when you, my wife does both the income tax and the insurance claims, and she says income tax is a lot easier than the insurance claims. And that just shouldn't be. I always kid my Canadian colleagues in spring break go skiing. I choose health insurance plans. And it just shouldn't be that it should be so hassle-some. The time patients spend getting reimbursed, if you price that out at $15 an hour, that's real money, much more than a profit.
Let me just add that I think there's 2 things you should be concerned about the insurance industry. Not how much money it's making. How well it does depends a lot on the bond market, because in between the time you pay your premium and the time that it needs to pay out the money, it invests largely in bonds. That's not really my concern. It's like looking in someone else's pocket. How well are they doing in the bond market? I don't care. What you need to be concerned about is, A, whether your insurance covers everything that you need in terms of effective treatment. Zeke's plan has one package that everyone gets that is extremely comprehensive, rather like Medicare, plus the things that young people need. Okay, I think his plan is better than 85% of all employer-based plans that people have now. And then secondly, you have to be concerned that insurers will turn you down if you have pre-existing conditions, or if you get sick, or if they'll charge you an arm and a leg. Under his plan, you all pay the same amount because you have one certificate, and they can't turn you down. The government will pay them more if an insurer ends up with more very sick people. But from your point of view, you can't be turned down, and they can't say, no, we don't cover that in this plan, because all the plans will be the same. And ideally, with the technology assessment, all the plans will be covering effective treatments. And there won't be any hidden holes, just as there aren't really any hidden holes in Medicare. It's very clear, by and large, what Medicare covers. And that's what he's talking about in terms of private insurance.
Yes. Hi. I have a question regarding, probably Dr. Mayer. The pharmaceutical, you touched on the comparative effectiveness cost, and the pharmaceutical companies and device makers, I guess. I started my career out in the pharmaceutical industry, and at that point in time, it was a long time ago, they were not allowed to advertise their proprietary products, only the over-the-counter products. And it seems that with the regulation, with the deregulation that has gone on over the last several years, 20 years probably, the cost of the drugs that people are using is based on their marketing plans and budgets. In my mind, there is no reason whatsoever for drug companies to be advertising to Joe America and Jane America on TV and in magazines. It used to be that it would only be in the trade publications directed at doctors. Is there any hope of going back to that? Because to me, that's a no-brainer to start reducing some costs.
We and I think New Zealand are the only countries in the world that allow direct-to-consumer advertising. Now, drug companies spend hundreds of millions of dollars on these very expensive TV ads. Why are they advertising to me? I can't write a prescription. So why advertise prescription drugs to me? For the same reason that movie studios sometimes put a lot of money into advertising a movie. And when you see an ad for a feature film on television, what does that tell you? It tells you they're very worried that they're not going to get the box office for the movie, and so they're trying to pump it up. When drug makers spend a lot of money advertising a drug on television, it's because they have a hard time selling that drug to the doctors directly, either because it's essentially a Me Too drug, not very different from what we already have, but more expensive, or because we don't have much information on it, and we don't know how risky it is because the trials weren't done long enough. So a product like Gardasil, the vaccine for supposedly to prevent cervical cancer, got a huge play on television. What doctors know is it wasn't tested long enough, and it wasn't tested on enough very young women, so we don't know much about it. But the hope is that if they advertise it directly to the consumer, then you'll go to your doctor and you'll say, I want this. And your doctor, who is busy, who has 10 minutes to see you, will say, fine, I'll give it to you. Go away. And that's what's happened.
But is there any hope for us to go back to regulating that?
The only hope, it all depends on essentially the composition of the next Congress and who's in the White House. And it would take votes, courageous votes, by people who are willing to stand up to the lobbyists and say, we're going to vote against the drug industry despite how much money you have in campaign contributions. The only way that'll work is if the public is putting enough pressure on congressmen. So the congressmen look in one direction, they see their constituency, and the other direction, the lobbyists. Now, the lobbyists have money for campaign contributions, but if your constituency has decided to vote you out, no amount of money is going to help you. That's what happened in July with the last legislation. Congress looked and they saw the AARP on one side, and they saw the lobbyists for the insurance industry on the other side, and they knew who to be afraid of, the AARP. But voters are going to have to put pressure on Congress in order to equal the pressure that lobbyists have, the leverage they have.
So your comment about the Congress and the President brings us back to, I think, an important topic. We started today talking about health reform and perhaps universal health insurance in New Jersey. And, of course, New Jersey is just one of 50 states. It's the most important of the states, but it's only one of 50. And so I'd like our distinguished panel, perhaps starting with Professor Reinert, to comment on whether meaningful reform of the health insurance market and of the health system is possible on a state-by-state basis. Are we likely to be successful in achieving much at all for our women, children, and other people here in New Jersey without real federal reform?
I think certainly Massachusetts has shown quite a bit is possible, although there one has to recognize they had a few things going. They had $500 million of federal funds sitting there to help. It's a rich state with relatively few uninsured by national standards, plus a fairly enlightened healthcare leadership, I would say, that respects one another and can get along and so on. And because I knew a lot of these people personally, and they work together in a way that's really quite exemplary. One could possibly do that in New Jersey because we're rich too and we don't have that many uninsured. But when you come to places like Texas, the whole Sun Belt, 25% uninsured, a huge gap between rich and poor in those states. The only way they could do any of this would be with substantial federal assistance. You know, like Medicaid already does. They get $1.70 for every dollar they spend. We get, 70 cents or 50 cents. So one would really have to think of subsidizing these places quite heavily. And that sort of raises the question that I asked at a conference in Washington recently. Are we actually a nation, or just a country, or a group of people sharing a geography? Because it really goes to this. We have Hurricane Ike is going to raise havoc in Texas, and no one thinks anything, no Republican governor or president thinks anything of making me in New Jersey subsidize people down there whose house got blown down, right? I mean, and we think it's okay. But I often raise the question when I'm down there to say, if a woman in Texas or Louisiana gets breast cancer, that's a national disaster too. So why should I then, if I help when the house is blown down, why should I not help the woman in Texas or Louisiana who has breast cancer take care of that, if we're a nation? You know, now if it's Bolivia, yeah, you know, they're not in my orbit, but if we're a nation, and that's why I often raise this issue. The problem with doing it is, with the states is also that if one state is very generous, there probably is some magnet that draws people into those states if they're very sick, because there they can get relief. And so you kind of set up a system where you export your misery to other states that are more generous. So that's a bit of a problem there too. But the real thing is that per capita income by state in the U.S. varies enormously, but the cost of health care is uniform.
Well, I would take a somewhat maybe more pessimistic view. I don't think any state is going to be successful, and actually the historical record, as bad as it on the federal level, is equally bad on the state level. Every one of the attempts to get universal coverage on the state ended up unraveling, and we're all hoping for Massachusetts to succeed because we need a model, but I'm also not very optimistic about that. I do think the gap, the number of people who will be uninsured is going to increase as the costs continue to go up. And I think a large part of the reason is that there's at least three components. One, I mentioned to you the tax exemption worth $210 billion that fuels the employer-based coverage system. No state can control that. Two, there's ERISA. 55% of employers are covered by ERISA, exempt from anything a state wants to do. They're out of the game. State can't control them. And finally, there's Medicare. Huge amount of money. Not only does it control a huge amount of money, creating the own incentives that diverge from what a state might want to do, especially in terms of quality of care and in terms of cost. But the way what Medicare covers, what Medicare pays, begins to set a standard for all private insurers. And so if you can't get your hands around that, your ability to change what private insurers do is much more limited. And that reduces the power of a state to have much effective control on the two things I said which were important, quality and cost control. And so I think, and actually Senator Ron Wyden from Oregon and I have a commentary coming out making this exact point that we really can't, I mean, you know, in the absence of federal leadership, it's perfectly understandable why New Jersey wants to do something and Massachusetts wants to do something, and California and Pennsylvania. But I don't think it's really going to be successful in the long term. And here's the indication about that. If you look at the numbers in California, and I would bet if you look at the numbers here in New Jersey, in California, to get to universal coverage under the Schwarzenegger bill, how much was being paid for in California and how much was he asking the rest of us to pay for? 40% of that bill was coming from us outside of California to pay for his reform. That's not a California reform. That's a California reform underwritten by the rest of the country. And similarly in Massachusetts. Yes, it was that $500 million that the federal government was going to take away that was driving this thing. So the idea that states are going to reform on their own needs to be put in quotes there. And yeah, people are going to be willing to tolerate Massachusetts do it, but if 50 states did it, you know, then we're back to the $100 billion question.
Yeah, I would just add that Massachusetts is a wealthy state. Right now, they cannot afford the universal care that they set out to provide. And that's because Massachusetts has no real way to contain costs, to say, no, we're not going to cover the bespoke need or the millions of other things that we now cover. We've got a lot of very good research out of Dartmouth that's been done over more than 2 decades showing that 1/3 of our health care dollars are wasted on ineffective, unproven, sometimes unwanted, overpriced treatments. And unless we squeeze out that waste, we cannot sustain health care for everyone. And the state doesn't have the control, doesn't have the power to squeeze out that waste. And that's why health care inflation in Massachusetts and any other state is going to just keep ahead of whatever monies Massachusetts can put into it. So I guess I'm really saying just what Zeke said, that you have to look at quality and cost containment at the same time as trying to provide universal coverage, or it's unaffordable.
There's also the added problem that you can really fake it. I think Senator Vitale this morning already mentioned we are the lowest paying state in Medicaid. The way we measure that is what are the fees we pay doctors here relative to Medicare, which is a national program, and New Jersey ranks the lowest. To give you some numbers, we pay a pediatrician $30 to see a Medicaid child. The commercial rate under commercial insurance anywhere $190 to $120. But I talked to state legislators and they said, you're telling a pediatrician your work is worth only 1/3 or 1/4 when applied to a poor child than it is when applied to a commercially insured child. That's the signal you're giving, and you're making that value judgment. And I'm not sure, I mean, that poor kid in New Jersey under Medicaid is nevertheless, I thought, an American who at some point we look to go to Iraq or Georgia and fight for us. So it's funny when they're military people, somehow they're national, but when it comes to keep their bodies healthy, they're state and local. I personally, as an ex-immigrant from Germany and Canada, find those very strange notions of nationhood. Very strange.
So I think I should...